Good morning, everyone. Good morning, everyone. Thank you. Welcome, and thank you for joining us at USAID's flagship Maternal and Child Survival Program's Community and Equity Moment, harnessing the power of communities to advance equity and primary health care for all. My name is Lisa Hilme. I'm the Executive Director of Core Group and a proud member of the Community Health Team at Mcsp. Before we get started, I kindly request you to turn off your cell phones or put them on vibrate, which I was reminded to do just a second ago so that my kids are not texting me. Thank you. We're thrilled that you can all join us here today for this important event, as you are all champions of community health, and it demonstrates the power that all of us together can have. The United States Agency for International Development, or USAID's, Bureau for Global Health's flagship Maternal and Child Survival Program, MCSP, focuses on 25 high-priority countries with the ultimate goal of preventing child and maternal deaths. The program was introduced and supported high-impact, sustainable, reproductive, maternal, newborn and child health interventions in partnerships with Ministries of Health and other partners. Our work is evidence-based and results-oriented. It is now my pleasure to introduce to you our first speaker, Kate Crawford, Deputy Office Director for USAID's Office of Maternal and Child Health and Nutrition. Ms. Crawford is a senior foreign service officer. She most recently served as Tajikistan's country director and has held posts in USAID missions in Southeast Asia, South Asia, and Africa. She has more than 30 years of experience in the conception, implementation, and evaluation of large and complex development, humanitarian, and interagency programs. Her tour includes DRC, Pakistan, Tanzania, Rwanda, so many different countries. And she is currently serving as the Deputy Director of USAID's Office of Maternal and Child Health and Nutrition, and in August will assume the Office Director position. Please join me in welcoming Ms. Kate Crawford.
Good morning, everyone, and thank you for the kind introduction. I'm busy changing my script. I had a 90-minute thing laid out, but I was told I only have 5 minutes. So first of all, I'd like to thank MCSP and the core partners for organizing today's session. Obviously, we have great esteem for both groups and the work you've done. So thank you. I've also bumped into some very good old friends, quite an esteemed group of community practitioners, so I'm really honored to be here. Let me just talk maybe a little bit about sort of AIDS, USAID's priorities, challenges going forward in the near term, because that's probably most interesting. Of course, under the current administration and going forward, preventing maternal and child deaths will remain pivotal to our programs. And in a sense, the maternal child health, the family planning, the health system strengthening, these are all kind of core development, unfinished pieces of business. Because you see more of this divergence into vertical infectious disease or disease outbreak, but I am quite confident that maternal child health, reproductive health, health systems, community-based health will remain for us a huge priority, and I think we consider that very much the core of our development work. Even as we move to the journey of self-reliance, some of the business models will change. Now the emphasis will be on helping governments, ministries, local partners to continue the journey themselves. But I just want to assure everybody that these program areas remain a huge priority. One change for us internally, and this is something I think we can learn from many of you, is how to better integrate these approaches and programs. But again, USAID's strength in the international development world has always been, I think, community approaches, community health care. So there's much we can learn from you. I think there's a lot of emphasis going forward on community approaches. So I continue to look forward to working with many of you. I'll just note two very important things about community health and community approaches that we're looking at. One is, as people get on treatment for HIV, as TB is brought under control, as new malaria methodologies are introduced, you're not going to have people coming to your facilities, or they'll come less and less. Now it's going to be about chasing them in the community, in the village, at home. So I think we're going to have to develop structures, methodologies to move from the facility down into communities in a much more holistic fashion than we have before. And part of that is going to be not only the methodologies, but I think finding very good metrics for what a good community health program is. I think the other big issue on the front burner for everybody is fragile states, and how you deliver services in fragile or humanitarian compromised environments, conflict. And what you increasingly see are hybrids. I mean, something like the DR Congo, where some parts of the country you have more of a sort of regular development program where you can do fixed site vaccinations and continue your basic health care, and then large parts of the country where the approaches are very much kind of emergency interventions, get in and out, emergency campaigns for vaccination, those types of things. So any way you cut this, the most important piece of all of this are going to be communities. They're always going to be the first to respond. They're always going to be our strongest asset on the ground. So again, I commend you for the work. I think actually going forward, it's going to be increasingly more important. Let me just say quickly, because I'm just coming back from Burkina Faso, which is another interesting, I mean, they too are dealing with this kind of hybrid of a government, a very committed government, which is now focusing all of its efforts on community health. I mean, they've built their whole, John may have to help me here, but the global financing facility, their investment case, the entire thing is community health. Very interesting. And yet, at the same time, they're also facing increasing insecurity in the north and the east of the country, and trying to grapple with how you continue community primary health care programs in that kind of an atmosphere. So, I want to thank Mcsp and CORE. I think between all of you, you have over the years developed some of what we consider best practices and some of the best methodologies. I think there's a lot that we need to now begin to put in practice on a wider scale. And I look forward to working with all of you to do this. And I look forward to hearing the stories of what you've learned and accomplished until now. So thank you very much.
morning. I'm Melanie Morrow, the Community Health and Civil Society Engagement Team Lead on the Maternal and Child Survival Program. I'd like to start this morning by taking a moment to picture the women, children, and families whose lives are affected by what we're talking about today. They live in communities at the so-called last mile from health services that may be geographically, culturally, or financially inaccessible. They are the faces of the global health goals and the motivation to achieve primary health care for all. And they're the reason to invest in functional, resilient systems for health. But for those who also like data, it's been projected that strengthening and scaling up community and primary healthcare platforms could avert over 3/4 of preventable maternal, newborn, and child deaths and stillbirths, with by far the largest share of those at the community level. In case we needed any more encouragement, investment in CHWs in sub-Saharan Africa can result in an economic return on investment of up to 10-to-1. And this is due largely to increases in productivity from a healthier population, reduced risks of epidemics, and the economic impact of increased employment. So the justification is clear, and yet communities often remain the invisible level of the health system. In terms of community health as a means to achieve equity, a 2012 Lancet review of strategies to improve health coverage and narrow the equity gap in child survival, health, and nutrition found pro-poor effects associated with strategies that included expanding the use of CHWs, task shifting, decreasing financial and geographic barriers, and increased use of the private sector. In addition, the comprehensive review of community-based primary healthcare programs led by Henry Perry and colleagues found that community-based primary healthcare was associated with pro-equity effects. So clearly, implementing community-based strategies is good for equity. To be effective, community health programming requires a continuum of providers. Services for high-impact interventions that span treatment, prevention, and health promotion, and implementation approaches that are adapted to suit the local context in a wide variety of settings. Reaching the underserved, predominantly poor populations depends not solely on Ministry of Health staff, but also on collaboration with NGOs, community organizations, and people working in other sectors to address the social determinants of health. And of course, a key to effective programming of all types is the importance of reflection and learning, both from data and from listening to those who are most affected. So we're likely all familiar with community health programs that excel in one or more of these areas, perhaps all of them, and yet in much of the world, we're a long way off from institutionalizing effective community health programs at scale. So we see fantastic projects in certain areas, but if we look across an entire country, it's rare to see really robust, comprehensive programs that are addressing, service delivery and community engagement across the board. So in March of 2017, nearly 400 community health champions gathered for the Institutionalizing Community Health Conference in Johannesburg and outlined 10 critical principles to accelerate country progress in health. So these principles encompass community engagement, frontline workers, financing, data systems, and the like. Principle number 6 reads that programs need to reduce health inequities and gender inequalities. And principle number 8 references partnerships to leverage and coordinate civil society and private sector, and engagement of communities to shape and support implementation. Copies of the principles and accompanying descriptions are available as a handout today. So with all of this talk about institutionalizing community health and integrating community platforms into systems for health, Where is community reflected in the prevailing health systems frameworks? A group of experts was assembled to respond to that question at a core group conference a few years ago. And the conclusion was that community was everywhere and nowhere. So a case in point is the WHO Health Systems Framework 6 building blocks of the health system. It serves as a common language for health systems planning, and yet community health in its many shapes and forms is hard to make out, and that matters. The framework that I'd like to walk us through now is one that MCSP and core group members worked on that goes beyond the building blocks to better integrate community health within national health systems. So the intended goal of the framework, as stated across the top, is healthy people and communities. And our framework starts with the essential determinants of the production of health. The household production of health is at the heart of things, and that's where families are caring for their own. They're affected by social determinants like education, gender, and social caste, reflected in the box to their right, and by access to quality health services, which is reflected there to the left. Now, service delivery is, of course, dependent on health workforce, including those who are community-based, like trained CHWs. So in these boxes on the left, you see we've taken the original building blocks, which are in pink, and defined an expanded community component in blue. Moving once again to the right, the framework places strategies for organizing and mobilizing social resources in communities in the context of systems for health. So that is community organization. And societal partnerships, defined by formal agreements with civil society, researchers, and private providers to complement the role of the public health sector at all levels, is another important component of the framework. At the bottom, we've retained a number of blocks from the original pertaining to products, vaccines, and technology, financing, leadership, and governance, with only modest revisions to how they're defined and incorporate community health. And we've situated health information as one ingredient of a larger building block dedicated to information, learning, and accountability. We really see that accountability mechanisms are important and need to be applied at multiple levels in the system. So our goal with this framework is to achieve a better fit for community health within national health systems and global guidance. And in doing so, we want to make explicit the often neglected investments and needs for community health that can be easily overlooked in the more common and prevailing frameworks that many people have top of mind when they're thinking about what they need to include in the health system. So in summary, we must prioritize community health and equity, including gender equity, if we're going to achieve the health targets of the SDGs and establish primary health care for all. We look to the critical principles to guide countries as they continue to develop and institutionalize robust community health programs. And by reframing how community health is situated in the health system, we hope that health decision makers will be able to see beyond the traditional building blocks to better plan for and resource community health as part of resilient national health systems. So in the country presentations that follow, we'll see examples that illustrate some of the critical principles and give life to elements of the Beyond the Building Blocks framework. So let's move now from the conceptual and hear from colleagues in 3 of the 18 countries where MCSP has been working at the community level in reproductive, maternal, newborn, and child health. So thank you very much, and I'd like to invite the country panel to come forward now.
Good morning, and welcome to the first panel of this morning's program. My name is Maria Francisco. I'm the Health System Strengthening and Equity Lead for the Maternal Child Survival Program, and I have the pleasure of being your moderator for this session. As mentioned, we will showcase 3 country programs that will serve to demonstrate the progress and challenges of integrating and sustaining community-based delivery platforms within these diverse systems contexts. And we'll also highlight the contributions these programs have been making towards improving RMN-CAH outcomes and achieving better health and gender equity. It's my great pleasure to introduce our panel. All of them have come from a very long way to be here, and we're very grateful for that. To my left, Dr. Ababa Bekele, former Chief of Party for Mcsp in Ethiopia. Welcome. Dr. Cilio Dimande, Chief of Party, Mcsp in Mozambique. Dr. Sikdar, Deputy Commissioner of Family Planning and Aspirational Districts, Ministry of Health, India. Welcome, Dr. Sikdar. Okay. I would like now to invite our first panelist, Dr. Ababa, to kick off the session.
Thank you. Good morning, everyone. I will be, in the next 9-10 minutes, I'll be sharing our experiences from Ethiopia's community-based newborn care program. Yes, okay. So, sorry. Ethiopia, for those of you who may not know, Ethiopia is a large country with a population of over 100 million, with about 60% of the population under the age of 25. We have a high total fertility rate at 4.6. The country is ethnically and culturally very diverse. About 80% of the population lives in rural areas. About 20% of the population live in geographies that need special support, meaning they either lead a pastoral, semi-pastoralist kind of life, or they live in very marginalized areas requiring special support. Over the past 2 decades, there has been remarkable decline in mortality in under 5 and maternal mortality, but the rate of decline in newborn mortality was very slow. And currently, newborn mortality accounts for about 50% of the under 5 mortality. And there is a lot of effort is needed to meet the 2030 SDG targets, as well as the health sector transformation plan target of the country. Coming to community health in the country, initiated in 2005, the Health Extension Program is the main community health platform for Ethiopia. It's composed of health centers and health posts. 1 health center and 5 to 6 health posts on average serve about 25 to 30,000 population. And the lowest level primary health care provision centers are called health posts, and they are manned by health extension workers, primarily women. And these health extension workers are tasked with disease prevention and health promotion activities primarily, but they also do some limited curative services, mainly focused on children. And these are government employees. They are on the government payroll. Currently, government has trained over 44,000 health extension workers deployed in all over the countries. A point to note here is the health extension workers, the health extension program functions very well in the agrarian areas, but in the pastoralist, semi-pastoralist, and areas that require more support, it's not as functioning as it's expected to be. Health extension workers are supported by what we call Women Development Army. These are 1 to 5 volunteer network, women networked in a 1 to 5 way, and they are tasked together with the health extension worker to mobilize communities and raise awareness, mainly focused on maternal, newborn, and child health issues. Reproductive, maternal, newborn, child, adolescent health, as well as nutrition is the major focus of the health sector transformation plan, and it's the focus of the health extension program as well. In the next few slides, I'll try to present briefly how the Ethiopian government used this platform to improve newborn care in the country. So the national newborn health goal, community newborn health goal is to reduce neonatal mortality through strengthening and introducing high impact interventions at the community level using the platform I mentioned, and enabling households to produce their own health. This is a key principle of the health extension program. Mcsp contributes to the national goal by supporting the implementation of high impact newborn interventions. And in 2013, the government of Ethiopia developed a community-based newborn care package to address very low care seeking for newborns, as well as complex barriers to that we face in early initiation of care seeking, as well as overall perception of whether newborns could survive or not. So there are complex issues that government wanted to address, and this program was developed in 2013 to be implemented nationally through the platform I mentioned, but that platform, as I said, mainly functions in the agrarian area, so it leaves out some of the marginalized population in the country. So this package is composed of multiple high-impact interventions, starting from early identification of pregnancy through the postnatal period. And in addition to the list of interventions I put here, the package also acknowledges the need for a systematic demand creation or community mobilization strategy using the Health Extension Workers Women Development Army platform I mentioned earlier. And in supporting the rollout of the community-based newborn care package, Mcsp targeted 135 districts, covering about 24% of the agrarian districts, about 20% of the agrarian population. We supported the initiation of CBNC in over 3,600 health posts, 730 health centers, and trained a lot of health extension workers as well as health workers. What is unique in the Mcsp implementation of CBNC was a systematic inclusion of a demand creation strategy, which is integrated in the national community-based newborn care training package. And Mcsp demand creation strategy focused on household practices and norms, including early care seeking, as well as enabling social environments as well. So the strategy used and strengthened existing platforms. One of the platforms is the one I mentioned, the Health Extension Workers Women Development Army platform, already tasked with community mobilization. In addition to that, we also used the existing lowest multi-sectoral administrative structure, which is called Kabale Command Post. And that structure had on average 7 to 9 members. We expanded that to include additional members representing, for example, faith-based leaders, TBS in their non-delivery roles, Women Development Army, other affected members in the community, for example, a husband that may have lost a wife due to birth, or a household with neonatal days. So this team passed through iterative community action cycle to identify, prioritize, and act upon MNCH problems, and then they also evaluated what they did. So at the end of the project period, we did both qualitative and quantitative evaluation, and we've seen that there were change in knowledge about MNCH in the households. There were less fatalistic view about neonatal survival, especially among mothers-in-laws. Hence, there was better neonatal care seeking. We also saw early initiation of ANC, early identification of pregnancy by health extension workers, leading more women into the continuum of care and capturing newborns early and treating danger signs. That was also improved. And we've also seen significant increase in women's perception of their self-efficacy as well as collective action to address MNCH problems. We also tried to model CBNC newborn mortality impact in the 4 regions we've been implementing. So as you can see here, there is variation in the regions, and I can explain that later if needed. But the modeling used 2 high-impact interventions, clean birth practices and PSPI management. The solid blue line here indicates mortality reduction without CBNC implementation. Dotted blue line is the expected target, and the red line indicates mortality reduction trend with the MCSP CBNC implementation. And as you can see from the graph, the implementation of MCSP CBNC has brought mortality reduction closer to the target. But here it should be noted that improvements were only possible because of comprehensive system-wide efforts to improve care seeking, not just because of the two interventions. So in summary, community health approaches provide important platform for large-scale implementation of high-impact interventions. It contributes to women empowerment and promotes inclusion, narrowing disparities. As you know, one size doesn't fit all. Community health approaches need to be adaptive, for example, for the pastoralist, semi-pastoralist kind of population. Integrating community empowerment approaches into existing platforms facilitates and promotes ownership and institutionalization. And as a recommendation also looking forward, the Ministry of Health is currently looking to optimize the health extension program to the pastoralist areas, and also to make sure that the quality of service that is implemented by partners continue as per the quality that happened during the project's period. Thank you very much.
Thank you, Dr. Ababa. I think this is a very good example of a program that really builds on the existing delivery platform, in this case, the Health Extension Program. Thank you. So our next speaker, Dr. Stelio.
Thank you so much. I would like first to make a little correction. I was not the COP. I was the technical director for the community component, working with Dr. Luj Vaj, which was the COP, and also with Betuel, Dr. Betuel, which was the other technical director for the clinical component. It's a pleasure to be here with you, sharing some of the MCSP Mozambique experiences and also learn with you. Mozambique in the last 2 decades had some important progress, but despite this fact, we still facing some challenges, and those challenges had an important, was considered relevant for the MCSP approach, and also aligning some global evidences with the Ministry of Health strategy documents, making sure that we implemented actions to contribute to reduce those important challenges. The project has as a main objective increase access, demand, and also the utilization of the quality gender transformative RNMC A and nutrition health. Also with prioritization with focus on malaria interventions at the households, at the community, and also at the health facilities. It is important to mention that we had a perspective, an integrated perspective covering different technical areas, capitalizing the GPIGO, the GSI, and also the PAT expertise to address different challenges. And we covered 2 of the 11 provinces that Mozambique have. We had an opportunity to reach more than 1,000 communities, and in both provinces we were close to cover 100% of the districts. In Nampula, was possible to reach the 23 existing districts, and in Sofala only the 11, considering the political situation we had in Sofala. Our approach was always focused on revitalize and strengthen the community platform's functionality. It was essential because in Mozambique we have a very high fragmentation in terms of community cadres. We have, as Dr. Abeba mentioned it, we also have APH, we called, they are the recognized community cadres. We have also traditional bed attendants, we have traditional medical illness, we have activists and volunteers linked with different programs, with HIV, with nutrition, and we made sure that all those cadres were linked with a formal platform, which we called community health committees, and also the community, the co-management and humanization committees at the health facilities. We also had a focus in strengthening those community cadres' ability and capacity to deliver services with quality, with focus in special in the ICCM. Our approach was also linked with the Minister of Health support, the Provincial Health Directorate technical support, the health facilities technical support, and also the community cadres technical support, making sure that they were able to provide quality services. We reached supported to revitalize 758 community health committees in the selected and targeted communities, and 82 co-management and humanization committees, making sure that each of the health facilities directly supported had a co-management and humanization committees, which is essential for the humanized approach. As a result, I would like to share these and some other slides that evidences the progresses across the years. We had as a target to reach 606 functional CHCs. Were possible to reach 758, and also was possible to reach all the health facilities, as I mentioned it, with the functional co-management and humanization committees. Also, was possible make sure the alignment between the different CBOs, the different community platforms, with the functional CHCs, which is the structure recognized by the government as an essential structure to link community cadres with the health facilities. Was possible also improved emergency transportation systems, starting from a mapping we made at the different communities, and also introducing saving and loans approach to raise funds to also support to strengthen the referrals. Was also possible expand the access for family planning services, for chlorhexidine also access. We supported the government to introduce in the main strategies the inclusion of some the task shift of some tasks for the APH to deliver certain services, including provide family planning methods, and also to provide chlorhexidine at the community level. Also strengthening the capacity of the cadres, in special APH, to provide ICCM, diagnose, treat malaria cases, diarrhea, and pneumonia cases. Also was important the different cadres' role to reach an important number of individuals through the different health education sections, the culinary demonstration sections, and door-to-door contacts to increase the demand for services. As an example, in the second slide, in my right hand, is possible to see the tendency of the number of women that attend, pregnant women that attend to the at least 4 antenatal care. Close to the end, I would like also to share that following a very simple approach, which we called health demonstration centers, was possible to establish in local materials. More than 1,000 of these demonstration centers established in local materials with a priority perspective to demonstrate how to build wash facilities and also integrating nutrition interventions. As a result of this, we had was possible, together with the communities and using the saving and loans approach, have additional households constructing improved latrines and also TP taps, which is really important in the perspective to have more clean communities and have the adoption of adequate behaviors. This is the last slide. The last note is close to the last. But here I would like to also share the in the baseline and the endline key APC results, which evidenced also the improve in terms of wash that was possible to do, and the last one, the suitable and home environment and clean spaces for kids play, was important to reduce the number of diarrhea cases in the communities supported. The last slide, in resume, is what we think is essential in the perspective to have a sustainability, and also in the perspective to have the institutionalization of the community interventions. We think that having these community platforms, the functional CACs, and social accountability process as a priority it will be always essential. We supported the development of a community scorecard, and this tool was recognized by the government, and in the GFF mechanism that we already started to implement in Mozambique, we used this tool also to support the community component of this approach. Thank you very much, and it was a pleasure.
Thank you, Dr. Celio. Again, some very good examples here, not only of utilizing the existing platforms for delivery, but actually better organizing the community health workforce to deliver on that common platform, linking the social network and this harmonized approach. So excellent presentation. I invite Dr. Sikdal.
Good morning, everyone. And when we talk of India, we talk of numbers. And without that, we can't begin. So while starting this presentation, I'd like to show you some of the huge indicators that we have, how we are really placed as of now against the global standards as well. I'll start with the first slide. It's talk about demographic scenario of the country. You have 1.3 billion people, in fact 1.35 as of today. We have 27 million deliveries per year, and we have about 253 million adolescents. And in fact, 50% of our population are in the age group from around 10 to around 50. So that is a very young country, you may say from that point of view, with a lot of productive population, but it really throws up numerous challenges for us, which we are trying to address in a very systematic way. Coming to the number of states that we have, I heard Ethiopia say about the diversity, but I somehow believe that the diversity was actually coined for India only, because if we have 36 states, actually there are 36 countries. You have one state like Uttar Pradesh, which is the 5th largest country in the world. So that is the magnitude that we are dealing with. We have around 725 districts. Some of the districts' population also are more than many of the African as well as Latin American countries. Every day there is 1 zero missing. 34,000 pregnant women are registering for antenatal checkups. And then you have around 2,200 institution deliveries every hour. And every minute there are 36 live births. Now this live birth used to be 60 around 15 to 20 years back. Every minute we have been able to bring down to around 38 right now. But we have done very well and faster. The maternal mortality ratio, if you are talking about, we started at around 556 in 90, and we have brought it down below 130. That is a 2015-16 figure. As of now, it is somewhere hovering around 100. So this decline is very, very steep. The 77% decline between 1990 and 2015. Similarly, for the under 5 mortality rate, if you see, there's a sharp decline. We started at a high of around 90, and then we brought it down to 39. And you see right now, we are at the global level, where for the first time, the share among the deaths, the global deaths, is equal to the share among the global births in our country. And this, again, is an old figure of 2016. Right now, we have come below this also. Two very important landmarks. We have eliminated maternal and neonatal tetanus. And for polio, in 2009, we accounted for 50% of the world's numbers. And by 2014, in just 5 years, we brought it down to 0. And we were certified polio-free by the WHO. And we have been able to maintain the same for the last 5 years. And this against the challenge of having 2 countries which are still polio endemic on our borders, like Afghanistan and Pakistan, where the vaccinators are not allowed to vaccine, and there are religious issues where the polio vaccination is not really allowed to go forward. We've done well on the fertility front, a 35% decline in total fertility rate, and the 2015-16 figure shows our total fertility as 2.2, which is again right now less than 2.1. So we have reached the replacement level of fertility, and that too we have reached very fast. And this figure, which tells us that in the year 2018, because of the contraceptive use in our country, we have been able to avert 4.4 million unintended pregnancies, 1.82 million unsafe abortions, significantly 23,000 maternal deaths. So that is very humongous, because if the family planning program was not there, we would have lost another 23,000 women. Right now, the number we lose around 22,000, but it's coming down very fast. Coming to the health indicators that we have done very well over the last 10 years is that we have declined our teenage fertility by more than 50%. Our full immunization is increased by more than 41%, almost 80% increase in early initiation of breastfeeding, and a 43% decline in teenage marriage. Now, this has a significant impact on the maternal and child health indicators that we are in our country we have. So what are the key drivers of the progress? We learned very early in our program, say in 2005, when we launched the National Health Mission, about espousing the community health goals, which are empowering the communities. That is at the base of all our planning. Accountable health systems, impactful national health programs, reducing inequities, and demand for quality health services. Since we are stuck to this, somehow the programs that we have launched and funded are really doing pretty well in the country, and we are getting the dividends very fast. So what have we done very recently? This is a flagship program of the Government of India, which is talking about Ayushman Bharat, which means Healthy India. We launched it because we wanted to take the healthcare to the people. And here under this, 150,000 health and wellness centers providing comprehensive primary healthcare by 2022. We are going to beat this target of 2022 because we already have 25,000 done in just 6 months. So another 1.5 years, we will be able to reach this 150,000 figures. Also, we launched the insurance program, the Pradhan Mantri Jan Arogya Yojana, where we are providing care to 40% of the population, which includes 10 million households and 500 million population with an amount of about $7,000 per year per family. This is again totally free to the clients to avail of secondary and tertiary care services in empaneled private hospitals as well as government hospitals. So what we have done in the Health and Wellness Center, what is different than what was there previously, is that we are providing an expanded package of 12 services, healthcare services closer to the community, which includes the RM and CHS services. We're providing free access to medicines and diagnostic through the Health and Wellness Centers, through reference and telereferrals and consultation with the district hospitals. We are engaging communities and developing community mobilization strategy to increase the awareness and demand generation for activities, and also promoting the wellness activities to ensure preventive health for the communities. And another path-breaking initiative which we launched for the aspirational districts. The reason why we call it aspirational is because they are basically the challenging districts and the weaker districts. So our Prime Minister said that if you say they are weaker districts, they will never work. They will be so demotivated. So let's call them aspirational districts. So they will try to aspire to reach to the other ones who are doing well. So we have identified them not on the basis of just health indicators. We have given the composite scoring based on 5 different areas which also contribute to health, which includes health and nutrition, agriculture and water resources, education, financial inclusion and skill building, as well as basic infrastructure. And aim is to really achieve the SDG 3 goals that we are aiming at. We have strengthening community processes, 1.3 million accredited social health activities, around 540,000 village health and sanitation committees. We have about untied grants for this. What we are saying, we believe in you. You are giving you money. We are giving you the power to decide. You spend the money to improve the health outcomes. And also there are 8 million village health and nutrition days. Just a little bit of the activities of Mcsp in India. It is in the arena of adolescent health, family planning, and health and wellness centers. The health and wellness centers, they are actually doing in some part of India, in some of the northeastern states. But for the family planning program, they're aligned with the Government of India's guidelines, which are reflected in this hexagonal things that we have given out in terms of gender sensitivity and respectful care, informed decision making, etc., etc. And also, this particular project has done some training about 32,000 community health workers, also capacity building on gender, social inclusion for providers, and also activating patient welfare societies together with advocacy and introduction of newer contraceptives. So coming to the last slide, we in the country, we always work together, and happily all the donors that we have are aligned with what we want to do. So they first come to us and they tell what they want to do. And if as long as it is in line with the Government of India's guidelines and plan of action, they're happy to go and work anywhere in the country, for which we ourselves write the facilitation letters. So there's an urgent need to understand the underlying causes of the service delivery and demand gap and address them through innovative, contemporary, and sustainable solutions. And all stakeholders, we believe, from whichever arena they come from, have to work together. So at the base is the philosophy with which we are moving ahead in the National Health Mission, is empowering the community is the only way to ensure quality health services, so working together with community pace. So if everyone is moving forward together, then success takes care of itself, and you can see in the happy faces of our community health workers, the Ashas. Thank you so much.
Excellent, thank you, Dr. Sikdar. It goes without saying that scale for you is something off the charts. It's really mind-boggling, the numbers. Okay, so I think we're going to start with our Q&A session. And before we do that, I will pose a question first. But I just think, just to set some ground rules for this session, I think if you do have a question, please introduce yourself. Ask only one question. Even if you have multiple questions, come around again, but allow as many people as possible to ask what they want to ask. Also online, we welcome you to submit either through the chat box or otherwise your own questions. Okay, so I'm taking the prerogative as the moderator, maybe just to kick off with a question of my own. And I would extend that question to all the speakers. So all 3 of these presentations, represent relatively mature community health programs. They've been highly regarded. I think many people have heard about these programs in other forums. But I guess because they have been so successful, it's attracted a lot of interest to utilize the same platforms for many things. So as you add more and more interventions and you demand more from community health workers, do you think, is there a breaking point? Is there a limit to which the health system can actually absorb more and more of these new interventions? Who would like to take that first? Dr. Abiba.
Thank you very much. That's a very interesting question, actually, and an area that the government of Ethiopia has been also very concerned with when partners started to add on, additional tasks on the health extension platform. So yes, I mean there is a limit to that, and that should be properly thought of. In terms of Ethiopia, what the government started doing is initially there was, because the health extension program, when it was initially developed, was focused on health promotion and disease prevention. It was off limit for curative services. But when it started to mature, like 5 years, 6 years through the program, few curative services started to be added, which made the life of health extension workers very difficult because they had to do everything plus curative services. So what the government started doing was shifting tasks to the Women Development Army. That's when the additional cadre of community health workers the government initiated that additional cadre. So I think it needs to be properly thought of, and I mean it's not a static kind of cadre, static platform. It changes. The demand also from the community changes as the health literacy, the people start to have more knowledge and information about their own health, and as the demand increases. So it's a dynamic system that needs to change, but yes, there is a limit, and it needs to be properly thought of and strategized for that. Thank you.
Thank you so much. Definitely, I think that the demand for additional interventions or additional task shifting will never end, considering that that the conscience of the different health stakeholders is increasing in the relevance of use community health workers to complement interventions and also to extend other interventions to the community, in special for health promotion. But the most important, I think, is at the time we are shifting some tasks for the certain community health workers, in especially Mozambique, that we have most of the interventions centralized in the APH, which are the former, the recognized cadres. We need to also start to incorporate the other community health workers, TBAs, the traditional medical healers, which are very recognized by the community, and the activists and volunteers shifting other tasks to these other cadres, making sure that they works together and complementing each to others. I think that Ethiopia has a very interesting experience with the health development armies, and we are trying to do the same, capitalize what other cadres can do to complement each to others. I think that is the most relevant. Thank you.
Yeah. Regarding the breaking point that you've mentioned, I don't believe that that break point has arrived, because experiences taught us in our country that there's been programs been going on for 15 years for the National Health Mission, and the ASHAs, the accredited social health activities, who've been there, the community health workers, on an average as of now, they work around 2 to 4 hours a day, which is not much. and they are allotted on an average for a population of 1,000. And there, if you see, the eligible couples would be somewhere around 170, and the number of births would be varying from 10 to 20, depending on which part of India they come from, which is really not much. And I believe that we are not loading them. Whatever initiatives and whatever programs we wanted to have, I think we are by and large complete. We've got so many flagship programs running, and now we don't want to invent or come out with any new programs. We just want to concentrate on these programs and really try to get the dividends out of this. So I believe that particular breakpoint will not not arrive for us. We are pretty happy with where we stand as of today. Thank you.
Thank you, Dr. Sikdar. The floor is open for questions.
Thank you, everybody. This is Hope Randall from the Defeat Diarrheal Disease Initiative at PATH. And from where I sit on the communications and advocacy side, we talk a lot about the importance of integrated approaches, including, of course, community health workers. And a couple of you mentioned the Global Financing Facility. I wondered if there are other opportunities that you would mention by way of integrated financing that could maybe address some of the barriers of siloed vertical programming.
We'll take maybe a couple and then.
My name is Samuel Usman. I'm from Core Group Polio Project Nigeria. My question is directed to the speaker from Mozambique. In my country, one of the major contributors to maternal mortality is delay during emergency obstetric care. And so you talked about emergency transport scheme. So I was wondering what you used it for, because the 3 delays in emergency obstetric care are critical in a woman's life being saved during an obstetric emergency. So I'd like you to shed a bit more light on how your emergency transport scheme worked and what were the metrics that you used to measure progress. Thank you.
Thank you. That was incredibly impressive what you people are accomplishing. I'm Ira Stolak with Cure Americas Global, and we all know a critical issue is keeping your frontline workers, your ASHAs, your HEWs, and so on, motivated. Okay, so if you could each mention what is the single most important thing you would say that you do to keep those frontline people motivated.
Okay, let's stop there and give our panelists an opportunity to respond to any and all. I think the first question is directed to everyone. Anyone?
Oh, thank you so much. This question is really relevant, and I think that in most of the African countries we are facing the same challenges. Definitely what we did was first start mapping the available existing transports. In most of the cases, was possible to see that the communities already have certain individuals or persons which have transport always available to support the different communities in emergency situations. It was the first step. The second step was also together with other entities working in the same area, identify available resources, and as a project was possible complement with seven motorcycle ambulances, but the government and the UNFPA also provide more than 1,000 motorcycle ambulances for the 2 provinces where we were working. And the third phase of this process was also work in the perspective to first develop a local system to raise some funds or some financial resources to support the maintenance of the motorcycle ambulances and other personal transports, and also to support with the fuel reposition. At the same time, was also possible train the different cadres to identify the different we called emergency dangerous signs, and make sure that identifying certain conditions in child under 5 and in pregnant women, the different cadres were able to refer using the different existing transports or motorcycles, ambulances, or personally available transport, and making sure that on time or in time they were able to refer to the referral health facilities. I think that it was the most relevant in terms of approach. Thank you.
I'm just going to intervene. I think for the question on the integrated financing, if we could table that for the next session. Dr. Sikdar also will be participating in that and can maybe elaborate, have some time to elaborate on that issue. But the other question around frontline worker motivation, if you could all respond, what the one thing that keeps them motivated. Okay.
I think picking a single thing may be a bit difficult. For the health extension workers, as I mentioned, they are salaried government employee. I think that the two important things that motivate them, I would say, is one is the government has developed, is trying to work on a career structure for them, so that is a motivating factor for them. Health extension workers with that additional treatment can become nurses or even go beyond that. But from the partners, the other, I think, motivation is the recognition that they are critical part of the health workforce, and openly acknowledging that in national fora, and also regular supervision, and when you go for supervision, acknowledging that and reinforcing that they are critical part of the system, their work is recognized, and they are saving lives.
Thank you. I think that despite the fact that in Mozambique, the only one cadre recognized and that which received a subside are the APH in the middle of different other cadres. The most important aspect for me is the supervision, regular supervision, and also integrate them to the former platforms as a community health committees, because integrating them, they will be always linked and recognized in terms of regular supervision, training, regular trainings, and we can conduct all the different supports using one common perspective in terms of regular support, not with focus on salary, because it's still a challenge for us. Thank you.
Okay, regarding the ASHA system that we have, they are not really salaried people, and they are not employees of the government. So this basically based on performance-based incentives that they get. The more they work, the more money they get. That is one of the one of the thing that they compete against each other is about. The better they perform, the more they get. That is one. Second is about the recognition they get at the district level or the village block level, as well as at the state level. And also many of them really get recognized at the national level also. And the third most important is basically self-motivation, because when they have become ASHAs, they have really got a voice now. Now, the women's empowerment thing has worked very well in the National Health Mission. So what we have said that in the National Health Mission, in addition to the improvement they're really doing in the health indicators, The magnitude of the women's empowerment that has happened with 1 million Ashas across the country is seen to be believed, because they're so proud, they're so independent, and they are actually our feedback system who tell us how the health system is functioning. So that being the case, that single motivation, that power to enter every household, that title that they are a village doctor, that really empowers them. And I'll give you one example, one or too many examples, in fact. When we ask some of the Ashas how much you're earning, in terms of the earning, it won't be much. It would be a few, for $10 or $20 or $30 or $50 or $100 a month. But they say it's not about the money. It's the dignity that we have. The village has accepted us. We are really able to enter each and every household at any time of the day, which was never the case. They are really breaking the socio-cultural barriers. So they would really trade that particular power that they have against, even if the payment is meager. That is the way the self-motivation is also helping out.
That's excellent. So I think we're running out of time, but I just want to acknowledge several questions came in from online that you have effectively answered without response. The questions were around efficiency, the motivations of community health workers. There were some additional queries that would dive more deeply into cost-effective training approaches, et cetera. But I think with apologies, we'll have to maybe respond, and clearly we can follow up with these discussions at a later time. But in the interest of time, I think I'm not going to be able to take any more questions. I see like the Time Lords telling me that we have to wrap up. So I'm just going to maybe just quickly summarize, if I may. I'll take 30 seconds to summarize what some of the things that I've been hearing, and also in the run-up to this, we've had a number of discussions internally also about some of the points we wanted to make. And I guess just to start that I think what's self-evident from the presentations is that community health is not just about delivering services through community health workers. I think there's been a lot of emphasis here on empowering community participation, inclusive decision-making, taking healthcare to the people. I think this speaks to many of the underlying principles of IHC, and ensuring that these community programs can be effectively institutionalized within the broader health system, but also sustained beyond the life of project support. Secondly, one of the hallmarks of MCSP has been to really generate the kind of data and evidence that would inform program investments and target resources to where they're needed most and can ensure the greatest impact. So I think there's been some very good evidence presented here about these achievements, the contributions that community health programs are making towards improved coverage, equity, quality access. And I hope that moving forward, again, countries would recognize the need to have very good data to inform and to sustain these gains moving forward. Finally, I think it goes without saying that the key ingredient to the success of these programs is sustained commitment and adequate investment in community health programming. I think part of that is also having the right advocates and champions with the right mix of skills, expertise, political savvy, to be able to actualize country commitments towards achieving these goals. 3 of those advocates are right here with me. I've had the pleasure of meeting them. So with that, I think, unfortunately, we have to close. I want to thank the panelists for their excellent presentations, for the audience, for their good questions, also our online crowd. And stay tuned for the next session, which is focused on catalyzing investments in community health. Thank you. Sorry, it was so short. Oh, sorry. Did everyone hear that? It was really so short.
Great, and while we're switching out our panelists, I just want to get a sense of who's in the room, and I'm particularly excited because as a nurse, this community event is happening during Nurses Week in the United States, and yesterday was International Midwife Day, so let's hear it for all the nurses and midwives in the room and at the community level. So let's get a sense of who is in the room as our panel 2 speakers and esteemed guests come up, please, and take your seats. How many of you consider yourselves practitioners? Raise your hand. Okay, great. And how many of you consider yourselves researchers? Okay, some of you might have your hands up for a while. Donors? Do we have any donors in the room? All right. Everybody look at them. No? Okay, no. Okay, no. And then how about students? Do we have any students in the room? No? Oh, we're always student. Very good, Ira. Thank you. Excellent, excellent. So I guess I'm going to take my seat now. We're going to get started. We're going to do this session a little bit different. We're going to have one question for all of the participants, and then we're going to have questions for 2 participants, and then take it to the audience right away. And we want not only the audience and online. And then we're going to finish with our other 2 panelists, and then take it back to questions, just to mix it up a little, keep you guys interested. Is that okay? And I will say, that since we're talking about finance and donors and country-level investment, I do have one caveat. And none of the questions can be related to current RFPs or future RFPs, because that might put everyone in an uncomfortable place. So it's my pleasure to introduce our 4 guests and esteemed colleagues. To my far left, Dr. Ann Tetchian from UNICEF, who is a health specialist with multiple technical expertise, not only in child health service delivery, ICCM, IMN, CI. She works in the Child and Community Health Unit at UNICEF headquarters in New York, but also has had a long history of HIV, early child development, nutrition, environment, expertise. So we're just really excited that Anne can join us today, and is also leading the child health redesign. So that's very exciting. And next to her, Lori Mioli, who currently serves as the Health Development Officer at the Office of Maternal and Child Health and Nutrition at USAID, where she manages 7 integrated community health awards. She is also on the AOR management team for USAID's flagship program. You might have heard of it, Maternal Child Survival Program, Mcsp. So thank you very much, Lori, for joining us. Liza Mesis, as is sitting to my right, who is the Country Investment and Knowledge Director at the Financing Alliance for Health based in Nairobi, Kenya, where she engages with a multiple spectrum of stakeholders, including governments as the primary clients, NGOs, global funders, banks, so many more. And she comes from a rich experience with finance, business development at various banks. So welcome, Liza, coming all the way from Kenya. Thank you. And you have met our colleague from India, Dr. Sikdar, who is a medical doctor, and I find one thing that is really interesting about his experience is that he chose to leave the clinical practice because he was very, very committed to public health and working at the community level and that leadership. So thank you very much for that commitment and what you've done in India at the Ministry of Health. So we're going to start off here. We've heard a lot about ICHC, the Institutionalizing Community Health Conference, in which we had 10 critical principles. And in those principles, there were 3 that I find particularly important that we're going to talk about. Investment, since this is the catalyzing investment panel, and really how to enable and ensure sufficient and sustainable financing for community health systems, as well as Principle 6, which dealt with programming to reduce inequities, and especially gender inequities. And then Principle 8, which is an investment of the development of the inclusive partnerships and the multi-stakeholder coordination, including civil society and private sector. So I'm going to ask you all, and we'll start with Anne, how does the work that each of your organizations or in the ministry that you're doing, how does it address and actualize these principles for financial inclusion, equity, and gender equity, not just talking about it, but making that investment and partnership?
Okay, thank you. Part of what I wanted to say to the second question is coming now, so I keep this one short. But I think that in UNICEF, the institutionalizing community health movement and our partnership with USAID and the Gates Foundation has really also helped to catalyze our own organizing around community health and really bringing our cross-sectoral focus of activities around targeting the community as a way to really reach those populations that are the most marginalized and disadvantaged. So I think, you know, at country level, we use the mechanisms that were established around the ICH very much to continue keeping these dialogues and groups that came together active and bring the discussion around financing and the need to really align investments that are mobilized by multiple partners around the community health agenda. At the global level, we do that in our dialogue with the partners, particularly the big funding partners. Now this year, very important, both the Gavi dialogue about the Gavi replenishment and the opportunities that are there way beyond immunization, as well as the Global Fund, where I think it's very important that we keep the dialogue active and make sure that community health remains a priority, and then sort of mirrored at the country level. And then we have certain tools that we use to make sure and to advise governments and also define our own programming priorities to make sure that we really reach those most vulnerable populations. So there's one tool that we're using called Equist, which really helps to identify in a country, both at the national level as well as the subnational level, sort of which are the most deprived populations and where are they geographically. What is the burden, the inequitable burden of disease that needs to be addressed in those populations, and then link that with the key interventions that need to be implemented and what are the main health systems bottlenecks to improve delivery of those interventions, and then sort of create models and financing models to deliver those interventions to the most marginalized. And we use this for our own planning, we use this to mobilize resources for UNICEF, and we use this to advise the government on how to, for example, make sure that vulnerable populations are considered appropriately in investment cases. So this has been taken on by a couple of countries. Ghana is one example. It's been used for global financing facility investment cases, etc.
Thank you very much. And important to mention some of the major replenishments that are coming up this year and UN's commitment to working with the governments and moving these forward. So thank you. And Lori, how about at USAID?
Yeah, I think the principles coming out of the Institutionalizing Community Health Conference have really been embraced by USAID, and USAID has worked with country delegations from the conference to implement the action and learning plans that were developed at the conference and move those forward. And so particularly the principles that you had mentioned, certainly USAID is working a lot with sustainable financing and innovative financing. That's certainly important on a country's journey to self-reliance. And the principle around equity and certainly gender inequities, addressing that. USAID has a long history of investing to reduce and improve equitable access to life-saving health interventions at scale. And as we all know, women often lack ability in many countries, in many health systems, due to social norms. They lack access to information and to services, and USAID has a number of programs at the country level where we're working in a very integrative way to support and empower communities to address these through, for example, SBC interventions or other interventions. So, for example, women can participate in leadership positions at the community level, or even at the household level, being able to make decisions about when to seek care for their newborn or for their child. And the last principle that you mentioned, partnerships, surely USAID is doing a lot in this. It's actually one of the three objectives of the Integrating Community Health, the ICH Awards, where partners are working to improve coordination coordination among, I would say, government, civil society, and private sector to push forward and implement policies and plans not only at the national level but down to the community level as well. And the ICH Awards, just quickly, are a partnership with UNICEF, the Bill and Melinda Gates Foundation, and USAID, and really pushing forward advancing community health in policies and systems. And one quick example of how we're doing that, I think, at USAID is through the Last Mile Health Award, the ICH Award in Liberia, where they've been working to improve capacity for the Liberia's Ministry of Health and community stakeholders to oversee and really scale up a high-quality national community health assistance program, the CHA program. Thanks.
Thanks, Lori. And USAID worked very much in cohesion with many of the folks that help plan and develop and participate in the Institutionalizing Community Health Conference. You can look more at the MCSP website as well as the ICHC website to see those principles again and really look at some of those presentations because it was quite a phenomenal event to really move us forward. Liza? Tell us about financing Alliance for Health and how those principles translate.
So the most applicable principle that we directly address through our work is on investments and financing and on partnerships. And for those who may not know, the Financing Alliance is a partnership that works primarily with governments, also primarily in sub-Saharan Africa, to explore different financing strategies for their community health and primary health systems. We all know that these systems need to operate at scale and they need to operate sustainably over time. And from the first presentation, we saw that the justification is clear. There's a 10-to-1, return on investment. So why is the investment lagging behind? And so in our work, we work with governments along the financing transition and financing pathway to move from reliance on donor funds to more of a diversified funding mix, which includes funding from different sources. And so, that's the main thing.
And Dr. Sikdar, can you speak to the government of India, especially your department, and how they are moving these principles forward? Thank you.
Yeah, thank you. I'm just the odd one out because I'm not the donor. The others are donors over here. So from that point of view, and I think we're sitting very pretty in India because somehow this global finances mechanisms is something that we have been able to do away with because we didn't need the money because it came with its own conditions. In fact, lots of conditions. So that being the case, we said that we probably have enough money to run our own health systems. So that is the way that we have done in our country. We have committed money for all the initiatives that we have launched in our country. But then, as I said, that donors are still working in our country. But if you see, I just want to give an example that at the turn of the century, the contribution of the donors for our programs were around 10%. Then it dwindled to around 2 to 4% into around 5 years back. And right now, it's about 0.7%. So that means that basically the donors have also understood that this particular country is self-reliant and they don't need the money as much because all their programs are actually backed by their own funds very much in place and assured from the Finance Ministry and assured from the Prime Minister's office. So that really puts us in a very different situation. But the fact of the matter is, even if this little trickle of an amount of 0.7% is coming in, we want to use it for catalytic purposes. For example, the technical support that we would need in some arenas. And what do I mean by technical support is that, for example, of course, there will be people who are from India itself, but they are high-end consultants or high-end technocrats or high-end specialists. Maybe the government system does not allow us to give them more money because nobody in India can earn in the government sector more than the President of India, which may not be much. So that being the case, we see probably this particular source available to us from the donor funding to really hire people with extra money so that they can really give us the consultancy that we want. Thank you.
No, thank you. And you said India is not a donor, but actually you've transformed, right? You're actually a big donor for WHO and other programs, and yet there's this interesting internal dynamic between the donors and India for your own country. So right now we're going to turn it over. We're going to go back to UNICEF with Dr. Detjian. And so Dr. Detjian, we know that UNICEF has a pro-poor approach and really is focused on equity-based programming. I'm wondering if you can explain that a little bit, and then also talk about the community health investment from UNICEF. Thank you. And everyone get your questions ready, because after Lori finishes, we're going to go out to you, and as well as people online. Thank you.
Yeah, thanks. So I think that the equity is the overarching principle under which we try to operate, which serves as a reminder of how we target the interventions and the investments that we make, where we work in countries, what we focus on, what we support, and that naturally led us to this focus on community. And I think, I mean, it was said before, we all agree, we realize we're not reaching the SDG targets, we need to accelerate progress. We also know that if we implement comprehensive services, particularly at the community, we will make a big difference and save lives. But in order to implement these interventions, of which we want to keep adding and adding and adding more, we need a system. The system is both the formal system that we try to institutionalize, so work with governments to make community health workers a formal cadre and an extension of the system that's focusing on facilities into the communities, but there's also the other big part of what makes the community what it is. And I think we recognize that there's a lot of movement in advancing the community health worker agenda, and WHO launched their community health worker guidelines last year, etc. So there's a lot of stuff happening and a lot of commitment by governments, and the maybe more challenging agenda that we all agreed to at the ICH conference was that we really, the role of the communities in holding the system accountable, in taking care of generating their health, which then helps us to address all those social and other determinants of health that the health sector itself actually can advocate for, but often not address itself. So I think there's a lot of work that we need to increasingly focus on as part of this really very broad community system that we try to build. And I think our work, which helps us in a way that we are multi-sectoral and that we are looking at community from many, many different perspectives and have a strong component also on behavior change, communication for development that addresses really, is reinventing themselves a little bit, this sector on really focusing on empowering communities. In terms of the investments, one thing I wanted to share is another joint initiative that we're working on very closely with USAID, the Rockefeller Foundation, the Office of the WHO Advisor for Health, is called the Community Health Roadmap, and you can look it up yourselves. There's a website called communityhealthroadmap.org. And this initiative is really a continuum of what came out of the institutionalizing community health movement, but also the recognition that there is a massive investment gap for community health that we need to address, and that many, many partners are starting to buy into community health, but that the efforts are not really aligned against what countries actually need. So the process or the goal of the roadmap is to really align around country-led and country-defined priorities and an agenda for community health, and then elevate these priorities, both at country level but also at global level, to donors and partners to really rally around a joint agenda and joint support. There is a set of 15 priority countries that were selected based on both the impact on health outcomes that a concerted effort into community health could make, but also feasibility in the country context. So has the government already made some kind of commitment for community health, including as part of the ICH, etc. And then the process really works that we go into the countries, or our in-country partners, the USAID and the UNICEF offices work very, very closely on the ground together, and to sit with government and all relevant partners to hash out the key priorities and their vision for moving the community health agenda, and then help to define those and present those in a way that's easily understandable and very clear, and then share those at the broader global level. Also, as part of this has happened in 6 countries so far, and the other countries are working on it, and there will be a more formal launch of the roadmap later this year. This has already helped and been used by some of the countries to, both by government to further sensitize other parts of the government towards mobilizing resources. It's been used to bring on board other partners, and it's been used at global level donor meetings to really present and highlight the priorities of those countries. Maybe just adding on how this community health focus fits in the bigger picture, because I think we also have to recognize that both the community health priorities in the countries are somewhat a moving target. One example is Uganda, right, where the community health extension worker strategy was put on hold after initially there was a big push for it, so we need to readjust, or the country needs to readjust what that means. But then we also have the global health agenda, and this is now the PHC and the UHC agenda, so we need to, I think, keep the focus on community, but at the same time make sure that we use the right language, and that we include the right partners to really truly embed community health within this bigger PHC agenda. And this is what the roadmap is doing, and this is how we try to also include the roadmap in something that's called the Global Action Plan for Healthy Lives, which was an effort triggered by a letter of 3 governments to the WHO to ask the big UN organizations and key development partners to really better align to achieve their health-related SDGs. And I think what that's done is created a dialogue amongst the partners on how, on the one hand side, we can better align work that we do, particularly addressing some of those cross-cutting areas besides our specific focus that we're all working towards, but also what are some accelerating themes where we can really make an impact and should all contribute to, and one of those is frontline health systems, where the community health roadmap folds in very nicely.
Great. Thank you very much. That's quite a lot, and I am really excited. I feel like this is community health's time, because we're finally talking about financing for community health and not just interventions. Having recently attended the UHC stakeholder meeting, I think one important caveat to add is, yes, we have the global action plan, but we really need to make sure that all stakeholders involved are not just checking the box of civil society and having a stakeholder meeting without actual action. So one particular exciting event, I felt that there was 6 asks for the UHC, and I believe now they're adding a 7th one, which is gender equality. So that is huge, I think. And a segue right now into Lori from USAID. So I know that USAID has always been a major investor in health system strengthening and valued community. Can you speak a little bit more about that? And also, how has it remained an investment, and how does it tie into the journey to self-reliance? Mm-hmm. Thank you very much.
Thank you, Lisa. Communities are really fundamental in fulfilling our mission. So without community involvement, our efforts really have a limited reach. And now, with the community health roadmaps that are being developed by countries, we're seeing a renewed focus on the role and contributions of communities as resources in primary health care. And we're seeing this commitment at the national level in many countries. And yes, on the journey to self-reliance, I think community is key. It's a key focus area. A mobilized community can and should support the health system in a country, and getting communities involved to participate in and advocate for their own health is essential. Empowering communities to take responsibility for their own health fosters self-reliance from the bottom up in a very sustainable way. And one example of how USAID is investing in this is through Humana People-to-People Congo's ICH Award in the DRC, where they are working with communities and community health workers to empower them, to build their capacity, and they're involving men, they're involving women. There's a special focus on youth and bringing the youth in to really not only build capacity, but to really increase the population's understanding of their own role in maintaining and having access to good quality health services that address the local needs. And I think USAID is also in many countries working to build the capacity, the technical capacity, but also the financial management capacity of community-based organizations in a number of countries. Again, this will have a lasting and sustained effect to support countries on their journey to self-reliance.
No, great. And I know there has been an emphasis recently on having new partners and folks and organizations that have not ever received money from USAID. So that would help in the strengthening part.
Absolutely.
Yeah.
Yes.
So right now I'm going to take it to the audience, and I'd like, if there's a roving mic or people online, don't forget to introduce yourself when you ask your questions. So questions for any of the panelists, or even the two that spoke most recently, UNICEF and USAID. I think I see Dr. John Barrazo there from GFF. Go ahead, John.
Thank you, Lisa. And thanks to all the panelists. It's a very stimulating discussion. So I'm John Barrazo with the Global Financing Facility. It's starting to roll off the tongue for those of you who know me. But my question is not from a Global Financing Facility perspective only, although I think a number of the things that were said about how do we actually better align behind country prioritization, how do we actually ensure that we're getting the maximum efficiency out of all the resources, including domestic resources that are going into those priorities, is very much aligned with what the GFF tries to do. But my question, though, is I think I think, Anne, you specified it quite well, that in fact this issue of community health is set within this broader context of the health system. And we have tools like Equist and other kinds of ways of gathering people together at country level that help us to determine priorities. What are the key health systems bottlenecks to achieving outcomes, to achieving impact, to achieving something which is increasingly on all of our minds, which is achieving quality. And so the question I have is, do we face a shortage of information coming from the community level that's folded into routine information systems that are increasingly going to be relied upon to inform that kind of decision making? More so, in my opinion, more so than survey data, because it's very robust, but it only comes around every 3 to 5 years. How do we ensure that the community platform is not only that the dimension of the community platform that's generating data information is adequately supported to be able to ensure that this is prioritized within this broader framework? Thanks.
Thank you, John. I'm going to take one more question online, and then we'll go ahead and answer that. So online, I'm not sure, thank you whoever contributed this. How do we mobilize countries to catalyze more investments for community health? And then do we have one more question from the audience before we answer over here? Thanks.
Thank you. I'd just like to echo everyone's thanks for this really interesting session, learning a lot. And I'd like to just a bit on John's point about the information systems and maybe push it even further, which is that I think we have a real opportunity with the enormous focus on quality now to really grapple with what that means around strengthening quality of community-based health services, as well as really robust community engagement in quality improvement efforts and quality assurance efforts within the entire system up through the facility. And I think we had a really wonderful example from Mozambique of the ways in which I think the government in Mozambique was really grappling with how to support quality at the community level, as well as the Ethiopia and India, but also how to really engage the community in a broader quality and UHC agenda up through the system. So I just wanted to, you know, I'm not sure it's really a question, but I would really appreciate hearing the panelists' thoughts on sort of where we go in terms of the information systems, in terms of the quality issues.
Okay, does anyone want to take the first question from John? And I think the second question, Liza's going to answer in her, the next question, so.
I can just say something about ongoing work on community health information systems. So under the Data for Health Collaborative, there is a group that's specifically looking at community health information systems. So thinking through what would it mean to have a system that's linked to the upstream health information system used by the country, collecting both data that community health workers need to do their job, and also the data that would be needed at higher levels to monitor and to support the community health system.
Okay. Well, no. I think right now what we'll do is we'll segue to Financing Alliance for Health. And Liza, I know that Financing Alliance for Health has had a lot of investment, blended investment, case studies, and different mechanisms for community health with governments as the main clients. Can you please discuss this landscape of the different financing mechanisms for community health, and how do we continue, as the online question is, how do we continue to mobilize these resources for community health? Thanks.
And before I go into answering the question, I would like to respond to Dr. Sidka with a comment on donors at this table. So our name is very misleading. Frequently when we go into countries and we say we are the Financing Alliance for Health, governments think we are coming with a pot of money, which is not usually the case. And to get into the question, so in terms of trends on financing for community health, community health in general, it's a moment for community health. So we see many countries prioritizing it, many strategies being written, and even countries with legacy programs, these programs being reformed. And that only increases the need for financing. And at the moment, community health is very heavily underfunded. Reports done by USAID, Financing Alliance, and others about a year and a half ago showed that there's a $2 billion annual gap in financing community health in sub-Saharan Africa. And this gap can only increase as countries are continuing to demand or to grow their community health programs. And at the moment also, majority of the funding is, dependent on donors, and it's deployed vertically through specific disease programs, which from financing perspective, I think it was mentioned earlier that it's not usually the most efficient way of doing things. And from domestic financing perspective, for the health sector in general, many African countries are still falling behind in their Abuja declarations on how much of their budget they will be spending on health. And that has a downward impact on community health as well. And so in terms of kind of what we need to do to close this $2 billion gap, in my view, number one, we need to obviously decrease reliance on donor funding. We need to increase domestic resources for health, and we need to explore alternative financing options. And so on financing mechanisms, I think my colleague over there mentioned that
to really achieve sustainable financing, we need the government to be on the steering wheel, taking a leadership role, taking a strong coordinating role, and taking a strong financing role as well. And to achieve that, for the health sector in particular, we need to strengthen the dialogue between Ministries of Health and Ministries of Finance. I recently just came back from, a country where, and even for the health sector in general, we need to really get better at making a good, strong investment case for not only community health, but primary care and health in general. So I just came back from a country and with meetings with ministers of finance, and they said, when education comes to ask for money, they usually have their ducks lined in a row. They will tell you how many kids are in school, how many kids need to go to school, what does that translate to in terms of productivity down the line. Like, they really have that case ready, and we really need to do the same in the health sector. We need to articulate the gains, not just in terms of DALIs and the usual, how many maternal deaths we are preventing, but we need to actually translate that into, so what's the increased productivity? What's the gains in employment? What are the bigger macroeconomic impacts of these changes to the wider economic landscape? So strengthening that dialogue between Ministries of Finance, we need to make sure finance is understanding priorities in the health sector, priorities in community health, and equally that, Ministries of Health are also, they know the budget cycles, they know how to present their investment cases to finance, and that relationship just needs to be strengthened. And we also need to take within governments, as part of increasing domestic finance, a multi-sectoral approach to financing. Increasingly, with the talk of social determinants in the financing landscape as well, what we are finding in countries is that Ministry of Education, for example, frequently has a budget allocated to health activities, so health education. We recently found out in another country that for any infrastructure projects, like constructing a road, there's usually a budget, a certain percentage allocated to health. And this is for things like putting up a billboard that, HIV kills, that says, some health-related message. And so identifying, all these pockets of money within ministries that can be better coordinated towards health, and usually with the health promotion, health education activities, it's usually, at community level. But we also find that even with strong investment cases, there's still a huge challenge to raising funds and a huge challenge to scaling up because it involves large upfront costs. Recently in our country also, with their community health strategy, they're looking to reform a legacy program, and one of the things they wanted to do is to build health posts, which is a huge upfront infrastructure cost. Some of them, they're writing a new strategy, and so upfront they need a lot of financing to develop guidelines, so it's a lot of stakeholder meetings and that type of engagement that needs to happen upfront. And I believe this presents opportunity to use, the limited public financing or donor funding to really catalyze more investments for community health. And here is where we talk about, innovative finance, blended financing instruments, or how they even use existing money and create a structure that, brings in more funds from private sector flows. Increasingly, we see investors are interested not only in financial returns, but also in social good. And here is where I believe there's still more work to be done. And resources like the recently released USAID's Blended Finance Roadmap are very, very useful resources that really provide a path in how we achieve this. And then we can also learn from other sectors here. Climate change, for example, have been quite good at this for a while. Green bonds are pretty much at this point permanent feature of financial markets. So how can we leverage lessons also from other sectors which might not be where returns are articulated in cash flow, but social returns and those kinds of returns that are not directly monetary at this point, but how do we learn from those sectors and how they've structured their instruments and kind of do the same for community health. And then eventually also to move to more sustainable sources of financing that are more earned income business models and in countries where the domestic landscape allows to move towards a tax-based system and also leveraging insurance. But this is one side of the equation when we talk about sustainability, increasing more, mobilizing more resources. We also need to look at how existing resources are used and how efficiently they're used. I believe there's still a lot of opportunity there. And opportunities for cost savings. You know, as mentioned, there's a lot of vertical money is deployed vertically in many countries for disease-specific programs. This leads to just a lot of duplication of efforts, and also from a coordinating role, everybody's just going in and kind of doing their own thing. I believe this fragmentation needs to, you know, stop. And with initiatives like the Community Health Roadmap, I believe those are really, really good ways to kind of bring everyone to the table. We also need to improve efficiency in disbursement of these funds. So even once they're, you know, we've achieved getting more money, then how does it go through the system to get to the actual place where it needs to get? A World Bank study a couple of years ago showed we lose hundreds of millions of dollars in just poor disbursement practices. We need to improve that.
No, thank you very much, and I'm sure we can get into more with the questions. And I think one of the most unique things about Financing Alliance for Health is how closely you work with the Ministries of Finance. And I suggest that all of you check out their website, because there's actual toolkits and a lot of data there on how to work with Ministries of Finance, and especially if you're working at the country level. So thank you very much, Liza. And now, Dr. Sikdar, thank you so much. We heard from you in the panel one a lot about the achievements and the scale of India's programs. And you spoke a bit about the Ayushman Bharat and the PMJAY for social insurance. Can you please elaborate a little bit more on this in terms of the financial issues and investment from India's perspective in reaching the communities? Thank you.
Thank you. First of all, one or two positive things, and then I'll talk about the issues. The positive thing is that the total health expenditure in our country, you know, it has really quadrupled over the last 10 years. That is something very good. And also, if you see, the percent of government health expenditure has also increased from 22% to 30%. That's also a very substantial increase. But there are still issues in terms of the out-of-pocket expenses. Now, the out-of-pocket expenses has come down substantially, but it's still about 60% of the household spending, which is very, very high. So even in the rural areas, people who can afford it are actually going to the private sector and spending a lot of money, wherein in the government sector, we have mandated that each and every service that we provide is free of cost. So whether it is in terms of transportation, whether in terms of diagnostics, or whether it is in terms of drugs, hospitalization, everything is free as far as the government programs are concerned. And also, we have seen the problems are more in terms of the efficiency of the spending that we have. Although we are disbursing the funds, the efficiency in it, as well as the monitoring mechanisms are not as robust as one would have liked. So that is something that we are really grappling with. Now, you mentioned about the Ayushman Bharat thing. Keeping all those things in mind, actually, before the Ayushman Bharat, when we launched the National Health Mission, you'd be surprised that the amount of money that we are actually spending every year, or rather allocating every year for the National Health Mission, is to the tune of about $5.5 billion a year. That's a yearly sort of a investment we make for this National Health Mission for all countries, all states of India. And as part of that, which is the Ayushman Bharat, which is within one of its wings, what we did was that there's two prongs to that. One was the creation of the health and wellness centers, as I said, 150,000 of them going on board by 2021 now. And also the insurance scheme, wherein we are actually covering about 10 million households and 500 million population, which actually amounts to around 40% of our total population. And the cover that we are giving is about $7,000 per year per family. So that's again through the national budget. So that way, our sustainability part is taken care of. Even for the health and wellness centers that we have, now we are actually using spending to the tune of $175 million a year. So health and wellness center is something that we think is probably the way to go to take the healthcare to the grassroots and to the houses of our beneficiaries. And we are very ambitious about this particular program. And thirdly, which I mentioned in my slide, was the Aspirational District program, as I said, where we are focusing an additional 30% budget allocation to the 117 districts of our 750 all districts, where in terms of the investment that we are making, we really have to see that they come up faster and come up at least level with the other districts of our country. Now, one thing which becomes very clear in the health sector, the other speakers have also mentioned, the return on investment on the health sector cannot be quantified that easily, because that particular return does not happen in 1 year or 2 years, 3 years. It takes at least 3 to 5 years for the investment to really show the results on the ground in terms of movement of the indicators. So we have to be patient with the spending, and I'm very happy to say that our government is very much committed, and the money that they have given is actually for a long-term sort of a thing that we really make some substantial improvement in our health indicators. So this is something that we have done in our program. So by and large, I think this is what we are thinking in the terms of that when we say that money is one part of the thing. In our national health policy, we actually, we had said that we will be increasing our gross domestic product, or rather the spending, to 2.5% of our GDP. In the National Health Policy 2017 we mentioned. Right now it stands around 1.15, but we are gradually going to increase it to up to 2.5 by 2025. That is one area where we are really looking at very seriously, and it is happening with every passing year. And last but not the least, is not about all the money that you are putting in for health. Is basically at the end of the day, how much health you get for the money that you're investing in. That is the way that we are looking in. Thank you.
No, thank you very much. And you were remarking to me yesterday that India is also unique in that the funding for health it comes from the Prime Minister's commitment himself, rather than the Ministry of Finance. So right now we're going to take some questions. Remember to introduce yourself and ask a question. And we do have one from online. I believe it's from Jean Sac in Japaigo. The question is, doesn't the in-depth consortia do this type of community-based collection of CHW data? I'm a little unclear, but I'm not, maybe it's referring back to John's question about community health data and feeding back. I'm not sure if anyone feels they want to answer that. And while we're waiting, I see, is there anyone else that would like to ask a question in the room? I see Dr. Eric Sario from Save the Children.
Well, Lisa's gotten very formal all of a
I
sudden.
have, sorry.
I've got a question, but maybe Dr. Sitkar in particular, but I think it's appropriate to the context. We have here donors and country leaders, so it's very interesting. And I know that right now, for example, India is, thinking very seriously about going back to a very comprehensive primary healthcare package. On the other side, donors, and a lot of us work with, the benefit of the donor funding. There's been priority setting that are heavy on, mortality, ending preventable maternal child death or reducing preventable maternal and child death, and we've seen what's been achieved. So those are two very legitimate mandates, but in terms of what community health is going to look like in the future and the flow of resources, what is it going to mean in terms of the balance between reproductive, maternal, newborn, adolescent, child health and more comprehensive packages that integrate NCDs? Thank you.
You're very right. A very appropriate question is, of course, RMNCHA is at the core. There's no going back on that because that's an unfinished agenda. But we talked about comprehensive primary care. Here in what we have done, When we say the Health and Wellness Center, it has a package of 12 services. Out of these, only 4 are aligned, or rather 4 are assigned to the RMNCHA. Rest of the 8 others are for other arenas, which are again big issues in our country, like communicable diseases, non-communicable diseases. You have accidents, trauma, all those things are there. So, in mental health, psychiatric, all the support that is coming in. Now, they are part of the 12 extended services that we are mandating at a subcenter level or at a primary healthcare level. So, basically what we are saying is that while not neglecting or not really forgetting about the RCH, where we really have we really need to reduce our maternal deaths and child deaths substantially, which we are doing anyway, but also the burden that we have in terms of tuberculosis, for that matter, is huge. The government of India has taken a huge decision that we want to eliminate TB by 2025. Now, on the face of it, it sounds very foolish and very ambitious. But the fact of the matter, in terms of the investment that we are making, in terms of the program changes that we are making, we feel that if not we are able to achieve it, we'll be very close to that. So what I'm trying to say is that the thing has been thought out very down to the last detail, and we are on our way to actually achieving comprehensive primary health care together with the RCH indicators that we want to.
Thank you very much. I'll take one more question from the audience. Do we have someone? Yes, Dr. Faleke.
Falake Lainka, I work with Mcsp on the immunization team. I want to thank you all for such an excellent discourse today. I'd like to look far in advance in the future and look at the kind of investments and the sources of the financing to be able to keep up and to increase the community-based interventions that we know are the backbone for universal health coverage. What is the role of private sector, and how can this be tapped for us to achieve the kind of goals that we are aiming for in investments? Thank you very much.
Mm-hmm. Thank you.
Thank you for the question. And it's, absolutely right and spot on that, we need to leverage not only private sector funding, but also private sector expertise and knowledge in building our community health systems. I believe that shift is already happening. In many countries right now, there's, obviously depends with the context in specific countries, but there's, I think, a lot of movement towards this. In a country that we were recently in as well, for example, they're looking at private sector partnerships, for example, as a way to really, number one, use the little money that they have from donor and public financing to really catalyze private sector investment into that project. And at the same time, the private sector is actually the one delivering a provider for these services. So in the future, I think private sector will become, a bigger and bigger player, and as it should be, and then will play a larger role in contributing a bigger share in the financing mix.
Great, thank you. And you can stay tuned for the next couple days to see the core group conference, which will focus on the private sector and a lot of financing for community health. Last question for UNICEF. I'm getting the stop sign, but that's okay. Give me a minute. Where can we find this wonderful equity tool for working with marginalized communities? That's from online. Thank you.
I'm going to say one thing about the previous question too, because I do think it's sort of a circle between the disease focus or the outcome focus versus the system. And I think this is a dialogue that we also need to have with the donor community and amongst us, because if you look at what is sort of the common denominator of the challenges that we face in achieving the disease-specific outcomes or the maternal and child health-specific outcomes, it's systems issues. And if we don't address the system, the successes that we have won't be lasting. So I think, maybe we need to, formulate it in a different way. And then at the same time, PHC is a lofty term, and we're talking a lot right now about pneumonia. Nobody's talking about, 1 million children under 5 dying from pneumonia every year. So how can we, use those disease-specific targets and say, if we want to measure if UHC and PHC actually deliver for children, we have to see an impact on pneumonia deaths, for example. So anyways, that's a longer conversation. The EQUIST tool, it's called EQUIST, EQUIST. It's on equist.info. You can find it.
Great, thank you. And I feel if I don't look at you with the stop sign, I still have time, but I'll sum up. We've heard a lot about rural communities. We've heard about equity, pastoralist communities, and fragile states. And I think that when we're discussing this financing, we can't forget these very important communities, as well as the general community health that exists at the ground level. I want to thank very much our panelists, Dr. Sikdar from India. Thank you for making it possible to come here and doing a quick turnaround back to your country so you can work with the communities themselves. Liza from Financing Alliance for Health from Kenya, thank you so much. We hope we see more of you in the future. Lori from USAID, who's a big champion for the Mcsp program for years now. And thank you, Anne, so much from coming from New York headquarters and working for child health and beyond. Please give them a warm thank you. And we will have our closing remarks now from Koki. Thank you, everyone.
So I'm going to be really quick. I hope you can see the wonderful quotes that we have flashing up on both sides, talking as voices from the field. And we've had a wonderful morning today. Thank you all for coming out and for those who joined online. We heard that we've seen what the global community has set out for us in terms of the SDGs. They're ambitious goals, and we know that countries have agreed to and committed to achieving these goals. But we also learned, and we know that for sure, we cannot achieve these goals if we don't focus on community health and ensure that services are available in an equitable and gender-sensitive manner for everyone who needs care wherever they live. Community health doesn't just bring health services to the last mile, but it also engaging communities in decisions about their own health and their own resources makes it much more responsive to local needs, and we can be delivered within existing resources. I just came back from Guatemala, and there were some wonderful examples of how the health commissioners had raised resources from the community and from, well, while all the visitors were there, they also asked us for, they immediately brought out their donation box. They were very clever. But they have some really interesting mechanisms of raising resources whenever they find opportunities so that they can refer a woman who was in critical care to a facility that is higher. We also had a wonderful panel from the countries, learning from Ethiopia, India, and Mozambique, that how community health programs can reach mothers and children who otherwise may not be able to access facility services, and which is key to achieving health equity and closing the gap between those who can access health services and those who can't. We've heard examples from countries on how approaches that strengthen community engagement and accountability, and how to complement the supply side with demand generation. And we need to make sure that these programs are happening at scale. But communities and community health workers can't do it alone. We have to make sure that these ambitious maternal health targets can be met only when community health is institutionalized into country formal health systems. And we've seen great examples from India and Ethiopia and others. It will require national commitment, policies, dedicated financing, strategies, the training materials, and, mind you, data collection from the community-based health promotion and service delivery partnerships and the civil society and other community stakeholders. We hope the discussion today revitalizes our interest and focus on communities and what they can do
to advance the unfinished agenda for institutionalizing community health into the national systems and what they can achieve in terms of delivering the health results that we all look forward to. So again, thank you all for coming. I have a couple of announcements. That there are resources available at the back, and if you see around you, there's multiple posters that have been put up, and you can grab your lunch, which is available outside, and then please do a poster walk. There will be resource people at each one of the posters to talk through some of the work that has been done if you want more information. Also, please make sure that if you can register and RSVP for the core group conference that is going to have even more interesting discussions over the next 3 days. I just wanted to echo again from MCSP's behalf, thank you all for coming and for participating and being such a wonderful audience, and for all the moderators and the panelists who came and participated in today's event. Thank you.